on interesting cases of glaucoma, and we really hope that the cases turn out to be interesting and we all have a delightful session. So we have Dr. Smriti with us, and Dr. Sushma Tejwani, and Dr. Geeta, and myself, Dr. Shikha. So we invite the first speaker, Dr. Shweta Karichari, to talk on glaucoma suspects, when and how to move forward. Dr. Shweta, please. We move to Dr. Surabhi Kapoor. She's here and she's presenting on a tumultuous journey on viral uveitis with inflammatory ocular hypertension and neurosensory detachment.
Good morning, everyone. I'm Dr. Surabhi Kapoor, a senior resident working at GMCH Chandigarh. So I'll be presenting. It's not moving.
You can keep the mic closer to you.
So I'll be presenting a case of a 47-year-old male who presented with blurring of vision for 2 months, with headache with occasional pain in the eyes, colored halos. He already had a medical history. He had got a LI 20 days back from Jammu and was started on maximum tolerated medical treatment in view of high pressures. So when we examined the patient, the best corrected vision was 6/6. However, the IOP, even on maximum treatment, was 44 and 46. He had patchy mid-stromal iris atrophy, and we checked the corneal sensations, which were diminished. The fundus examination was within normal limits. However, closed angles were seen in the left eye and one quadrant in the right eye. So the structural and functional imaging were also unremarkable. Keeping in mind the decreased corneal sensation, patchy iris atrophy, we were looking for a viral etiology, and therefore we got a torch serology done. And the patient came out to be IgG rubella and HSV positive. We also sent a AC tab for PCR, however it came out to be negative. So keeping in mind all these, and even on maximum treatment when the pressures were uncontrolled, we first made a diagnosis of viral uveitis associated inflammatory ocular hypertension, and we planned the patient for augmented trabeculectomy with MMC. So on post-op day 1, we had a happy patient, good bleb, no evidence of hypotony. We started the patient on valcyclovir. We did it under the cover of valcyclovir, and we give the routine post-op medications as given to other patients who undergo trap. And then we had a surprise on post-op day 9 when the patient presented to us with a decrease in vision in the left eye. So we got an OCT macula done, and we saw a neurosensory detachment. We studied about it, and we saw that there are very few reports, especially one report with a Sturge Weber syndrome patient who had a neurosensory detachment after trabeculectomy. So we were more likely thinking towards an inflammatory cause. So we just started the patient on tablet prednisolone 1 mg per kg. However, poor patient lost to follow-up for about 6 months, stopped all medications on his own, and later presented to us with fibrinous exudative retinopathy. So this is a picture showing the media clarity of grade 2 with the fibrinous exudative retinopathy on the superior temporal arcade. OCT through the lesion shows signs of fibrinous exudative retinopathy, and OCT through the macula still shows a persisting NSD. We got a FFA done to just confirm our diagnosis, and we saw a leak. So we studied more. We just saw that intravitreal brolucizumab do wonders in these patients. However, only one case study was there, but we took the chance, and post brolucizumab, it was magical. The fibrinous CSCR resolved. No NSD seen in the patient. So use of brolucizumab for fibrinous CSCR is not yet widely reported, but it demonstrated remarkable efficacy in our case. And just going by the title report, in patients who have viral uveitis with such high IOPs, so showing signs of inflammatory ocular hypertension, we should start them on tablet valcyclovir, and we should do it under the cover, and we should always be very careful that we can get some extraordinary responses post-treatment as well. Now, what was the USP of our case? It was a bilateral presentation of viral uveitis associated intraocular hypertension. There was a development of fibrinous CSR following an uneventful augmented trabeculectomy for an inflammatory glaucoma, which has not been reported so widely, and the resolution of fibrinous serous retinopathy with a single intravitreal brolucizumab administration. Take-home message: corneal sensations must be evaluated in setting of high IOP with signs suggestive of previous episodes of uveitis. Bilateral IOP should be documented for chronic inflammation, multiple mechanisms, systemic associations, and unpredictable response to treatment make uveitic glaucoma challenging to manage. Thank you.
Thank you for the presentation.
And I have a couple of questions.
Yes.
So you had high IOP in both eyes, right?
Yes, ma'am.
And you initiated treatment with valsiclovir and with antivirals, and then took up for
Ma'am,
surgery.
firstly, the patient had this patchy iris-stromal atrophy, corneal sensations were decreased. So we were thinking of viral etiology. So we got the torch test done first. Once the IgG rubella and the HSV came out to be positive,
On serology.
yes, ma'am.
Yeah, but this is IgG or IgM?
Ma'am, this was IgG, but we consulted our the infectious physician in our institute, and under his recommendation, he was like that we should start the patient on valsiclovir. So
Okay.
it was a collaborative approach between the
Yeah,
infectious physician
Yeah,
and
right.
the
So I have two
ophthalmologist.
questions then.
Yes, ma'am.
Yeah, so did you look for rising or falling titers after a week?
No.
Again? No. Okay. Second question. For how long did you give the antivirals and medical management before taking up for surgery?
Ma'am, before taking, ma'am, in these patients, we have to give it for a prolonged period of
No,
time.
my question is how long did you try medical management before you took up for surgery?
Ma'am, this patient was already on medical treatment for like 1 year. He was already. But you are talking about antivirals.
Glaucoma.
For glaucoma, yes, ma'am, that is what I am saying.
Okay.
So when he was referred to us, he was already on medical treatment for like 1 year. He was on maximum
How many
tolerated.
medications?
4 medications along with 2 oral medications. He was with glycerol and acetazolamide
Right.
as well. So he
Okay.
was in all these, and still the IOP was not controlled on
Right.
medical.
Second question. So
Yes.
when you took up for surgery, did you send the AC
Yes, ma'am. I
For-
mentioned, yes, ma'am.
for
Yes,
yeah,
ma'am.
and
Yes.
that also showed
Ma'am, that didn't show, but it was
that
not.
was not negative.
Yes,
That
ma'am.
was negative.
But that was negative. Yes.
Right.
So nice presentation. Do you also have CPs to share with us? The iris atrophy and the. And you said it was unilateral iris
Yes,
atrophy.
ma'am. It was more of a. I can say it was more of an iris hole kind of a picture.
So that would have been interesting to see. Do you know something about BD, the bilateral
Yes,
acute
ma'am.
depigmentation of the iris?
ma'am. Patients who instill more of fluoroquinolones, hydrofluoroquinolones, they usually present.
And even post-viral can also present like this. So now what is your approach in your center? So do you routinely do AC taps for pictures like Beatty, or do you start with valacyclovir or preemptively, and also on steroids? And another thing, did you notice pigments or cells? Did you notice the difference between pigments and cells?
Yes,
Were they
yes,
actually
ma'am.
cells or
We-
pigments?
Yes, ma'am. That we looked very carefully
Because
we
with
were-
depigmentation and iris atrophy, there usually are pigments which also resolve with steroids. So that you must see always. Now, what do you do?
Yeah, so one typical thing I would say about the case that you presented is it is not always true to have corneal sensations affected if you have a viral uveitis actually. That is more of a corneal viral involvement. You do not, I mean it is very peculiar that you had a corneal sensation drop. So I'm not sure whether it is related to the viral uveitis per se or anything else. Regarding the treatment of valsiclovir, well, I'm not a uveitis specialist though, but generally we do an AC tap for all patients who have uveitis like picture, whatever surgery we are doing. And based on the PCR only we start antivirals.
No, ma'am, ours was negative, but we still started the patient.
So you do trabeculotomy for both eyes?
No, ma'am. Initially we did it for the one eye, and then later we did for the
So you can actually see trabeculous uveitis and CSR with the Beatty kind of picture as one
Okay, ma'am.
spectrum.
Okay, ma'am.
So
Yes, ma'am.
it was an inflammatory etiology, so it would affect anterior segment or rather than differently. So Avastin or the anti-VEGFs can help that also.
Yeah. So there is something called as presumed viral uveitis where you treat empirically with antivirals, and in those situations you do give at least a week of antivirals and steroids before you go ahead with the trap, so that you get less problems with the macular involvement and post-operative inflammatory things, is what I want to add. Yeah, so we can have the next speaker, Atika Javed Siddiqui. Yeah, okay, she will be talking about mystery of a unilateral pressurized eye. Please go ahead.
Thank you, ma'am. So my case is, as ma'am said, history of a unilateral pressurized eye. My case was a young male, and he came to us with blurring of vision in the left eye for the 2 months, which was associated with mild ocular pain, intolerance to light, redness, and it was more around the bright lights. And this used to occur more often in the morning, and it used to resolve within 4 to 6 hours. And such attacks used to occur every 1 to 2 times per month. And there was no history of any ocular trauma, any curtain effect, any flashes of light. Past history, family history, and personal history was not significant. The general examination and system examination did not contribute to anything. And in the diffuse torchlight examination, everything was normal except for slight congestion in the left eye. In the ocular examination, everything was normal except for the high raised pressure in the left eye. On NCT it was 50, and on GAT it was around 48 mm of Hg, and the pupillary reactions were sluggish. On the slit lamp examination, the right eye was normal. In the left eye, we could see a diffuse corneal haze, and we could identify the KPs in the inferior portion of the cornea, and we could also see cells and flare in the anterior chamber. The fundus in the right eye was normal. In the left eye, we could see a CD ratio of 0.6, and although the NRR was healthy. Gonioscopy, the angles were normal. The perimetry was by and large normal. The OCT was normal. So we started him on estezolamide 500 mg STAT and then TID, and on topical anti-glaucoma drugs, and he responded to this for the meanwhile, and we also started him on an antibiotic and steroids. And we kept him on treatment for around 1 month, and he responded to the treatment, and we generally withdrew the steroid, and he was keeping good on that. But again, after almost 4 months of treatment, he again presented to us with high pressures and the KPs and all. So again, we put him on estezolamide, and we followed closely. This time we did not give him a steroid because we were suspecting that he could be a steroid responder. So we put him on nepafenib. But he did not respond, and on almost 2 weeks, 1 week after the treatment, he was still having a pressure of 42. So this is the GAT values over time which the patient had. And we came to a provisional diagnosis of a Posner-Schlossman syndrome because it was a unilateral presentation. He had recurrent attacks of IOP with anterior uveitis. The angles were open and there were no visual field defects. And these were the differentials we had in mind. So we planned for a left eye trabeculectomy with mitomycin C and mannitol as the pressures were high, and we monitored the vital. And this was a picture of a post-op day 1. The patient responded and the pressure came down to 25. And on post-op day 10, the pressure came out to around 10 and the patient is doing well. We still have the patient on follow-up, and we are looking for the other eye, if the other eye is okay or not. So Posner-Schlossman syndrome involves episodic unilateral spikes in intraocular pressure with minimal inflammation and mild visual discomfort. It has associations with autonomic dysregulation and viral infections, particularly cytomegalovirus, and it may often go unnoticed. Symptoms include blurred vision and mild discomfort, which our patient had, and without significant redness or pain, but our patient had pain. The differential diagnosis may include acute angle closure glaucoma, herpetic keratouveitis, and Fuchs' iridocyclitis. So IOP is usually managed with beta blockers, alpha agonists, and carbonic anhydrase inhibitors like we did, and corticosteroids, they help control inflammation. So surgical interventions like in our patient we did a trabeculectomy. It may be necessary to prevent recurrent attacks. Since our patient was young, we did a trabeculectomy to prevent further damage to the disc and further progression of glaucoma. So although PSS is often self-limiting, repeated episodes may lead to glaucoma, and long-term monitoring is crucial to prevent progression to open-angle glaucoma. So the take-home message is that the rise in the Posner-Schlossman syndrome, the rise of IOP is out of proportion to the severity of the uveitis, and this rise in IOP precedes the identified inflammatory reaction. A high index of suspicion is therefore necessary. Thank you.
So, interesting case, Posner-Schlossman is available.
Yes.
Yes. Right. Okay. Yeah. So did you do a PCR for CMP before doing a track?
No.
Okay. And another thing which I find, I'll just go with my chairs also, what do they see? I find very often in uveitis we use an antibiotic steroid combination. There is virtually no rationale for using antibiotics, and we've seen just now the body and the weight with the moxie and everything. We should stop using a combination therapy for uveitis. There is no proven rule of putting moxie or gati or Oflox. So in future, just give plain steroids for this thing.
Right.
And why did you think it was a steroid responder? Because he had multiple episodes as per the history, and that time he wasn't on any inhaled or oral or any
No,
steroids.
he's a young patient, he was not giving any history. But in a country like ours, it could be like the patient is hiding something or he's not giving a proper history. So the next time when he came, we did not purposely give a steroid. So that we have to rule out all the causes before taking up for the surgery.
But moment you have KPs and do you have flare in this patient or just KPs?
Mild flare, but cells
So
were
mild flare and KPs causing a uveitis, there is no option but to give steroids. You know, it's a double-edged
Yes,
sword,
yes.
but you have to do that because you have to prevent glaucomatous damage. So my take would be definitely it's a very worked up case, and it's always a diagnosis of exclusion partial enhancement. But if you have the option, do a PCR. All the time option is not there, but definitely do not use an antibiotic steroid combination.
Ma'am, I have a question, I'm sorry.
please.
So if, because I can take the opportunity to ask to you, but if you do a PCR and we find it is a positive for CMV, so what would be the take ahead message and what? how
Then
would
you start treating for the CMV or the virus which you find, because the recurrence can happen, and usually it is unilateral, but it may go into the other.
Because we
So
have the
it's for
patient-
prognostication of
Yes, ma'am,
the.
because we have the patient for follow-up, so maybe we
But
can
now
go
to
back
do an
and...
aqueous tap, intervention procedure, now you have to justify that.
So, ma'am, can we go for the other eye also?
No. Why? If there's no, see,
So we have-
anything which you have to intervene, aqueous tap has to be done. If there's no symptoms, you would not. But if you were doing a trap, at that time you could have taken the aqueous tap and studied that. So that's just a learning. All the patients come to us with learning.
Yeah.
So next time when you do, arrange for that.
Any role of oral antivirals in the initial part of management?
Two comments related to the case. So one is in the clinical picture you showed, the affected eye had a cupping of about 0.6 and the
Yeah.
other eye was normal, and KPs also were there in this eye. So very likely the patient has had previous episodes, may not have been symptomatic though.
And he was having a
Yeah.
history of around 1 to 2 months. He has showed elsewhere. He had
Yes,
no documents. And we were suspecting, and he was going into progression.
Yes, so no, not just that. All I'm saying is that given the 0.6 cupping, because Posner-Schwarzman is typically a recurrent kind of a picture.
Yeah.
So most likely he has had previous episodes, but they were probably not symptomatic, so he has not sought treatment. That is the first comment. The second comment is that in Posner-Schwarzman, when you look at your case carefully, you stop the steroids completely, and the patient came back with a recurrence and a high IOP.
Yeah.
Right, so I think at that point of time it would have been wiser to start the steroids and not the thinking that he's probably steroid responder.
And at that time,
Yeah.
we did not look for till the time he was having inflammation in the AC, we started him on steroids. But the time the inflammation subsided, we tapered the steroid.
Absolutely, so at that time there was no high
Yeah,
IOP.
yeah.
So that goes against the diagnosis of a steroid responder.
Yeah.
And when he came back, you should, instead of giving a nepafenac, maybe if you had given steroids, that would have controlled the episode and would have avoided the trabeculectomy altogether. That is the first, but again it's speculation because we don't know what happened to your case. Okay, the second comment relates to the antiviral which you were asking. So of all the studies that have been done in Posner-Schwarzman and what has been found, what I have read earlier is that topical ganciclovir can help in preventing the recurrences in patients who have recurrent episodes. But again, recurrent episodes would be at least at least you have some 3-4 episodes. So topical ganciclovir may help. So you could look that up further. There is a very nice review on this. Yeah.
Thank you.
So I would also like to make a comment. So it was an excellent discussion and a different case, unique case. But what I saw was your post-op picture. It showed some Sinicate in the immediate post-op picture, and the medications that you put the patient was cycloplegic HS.
Yeah.
So post-trap, we generally give, cycloplegic cycles to prevent posterior Sinicate formation. That is very important because once you form the posterior Sinicate in the immediate post-op period, they tend to remain for life. So the people should be kept
day one,
mobile.
and he responded well to tropicamide.
Your
You don't
pictures
give
showed,
cycloplegic,
yeah.
you don't give tropicamide. For traps, either you give atropine or you give homatropine or cyclopenthenate, whatever the protocol is. But tropicamide definitely is not adequate enough. In fact, we give TDS for the first 1 week and then we triple down to
Cycloplegic,
H.
ma'am.
Yeah, always cycloplegic. In children, atropine because they have a more, and uveitic, you're leading with a uveitic glaucoma now.
Yeah.
So you have to give cycloplegic. Thank you. I think we have to, otherwise we'll not be, that's a very interesting discussion happening. Can we have the next speaker? So we have here a case of steroid-induced glaucoma and carpet in a case of juvenile allergy. Dr. Abhishek Sharma, please. Maybe the next speaker can be ready so that we, Dr. Risha Kumari is there? Yeah, so be ready with the moment the discussion starts to be there so that we don't waste time in the transfer.
A very warm morning to one and all present here. Today I will be showing all those cases that we have encountered when we organized the camps in the remote areas of Himachal Pradesh, 200 kilometers from the tertiary center. So beginning with the first case. So it's a 17-year-old male who presented in the camp to us with chief complaint of diminution of vision in both of his eyes. And there was no any ocular complaint from his side, and examination was also normal as far as systemic examination was concerned. So he's a educated patient. He was a student of class 10th, and what he revealed was quite astonishing for us. What he revealed is that he was using certain sort of drops for the last 4 years, and when we procured the drops from him, it was a combination of ciprofloxacin and dexamethasone eye drops, and he has used over 50 vials of these drops in the 4-year duration, and because of which what we observed is that he is having a significant glaucomatous cupping in both of his eyes with a significant RNFL thinning, and optic cup to disc ratio in both of his eyes was 0.8:1 in the right and in the left eye it was 0.9:1. Relative afferent pupillary defect was present in the left eye, and posterior subcapsular cataract was present in both of his eyes. He was a reluctant patient. They were not willing to come to the hospital because of his family members. Actually, the mother was not willing to take him to the hospital. Vision was 5/60 and 2/60 in right eye and left eye respectively. So we brought him to the hospital with our own expenses, and the steroids were stopped. And he was given anti-glaucoma medication at the hospital, and we reviewed him after 2 weeks. The pressure was 20 mmHg in the right and left is 24. So on the follow-up, we planned for surgical combined extraction with a trabeculectomy, and on the subsequent follow-up, the right eye pressure was 12 mmHg and left eye was 14, and his vision was 6/24. But right now his right eye vision is finger counting. Another case, a 15-year-old male who is a daily wage worker, also hailing from Himachal Pradesh. He also came with the chief complaint of diminution of vision, and what he told was he has been using topical drops since his childhood without any visit to an ophthalmologist. This was the status of his disc in both of his eyes, in the right and the left eye. The optic cup to disc ratio in the right eye was 0.9, both is 0.9. This is the OCT image of this patient, where you can see a significant deep cupping with a significant RNFL loss in both of his eyes. Pressure in the right eye is 40 mmHg, left eye was 34 mmHg, and we planned for a trabeculectomy surgery for this patient. And after the trab surgery, the right eye pressure was 16, and in the left eye it is 14 mmHg. Vision in the right eye was 5/60 and left eye 6/36. Later he was diagnosed with amblyopia in right eye. I have not come here to highlight what the steroid cause, because it's an age-known fact that the side effect of the steroids is glaucoma and cataract. What I want to highlight is that the source of steroids, lack of awareness, absence of medical supervision. All of these patients have procured their steroids eye drops from the local practitioners or the medical stores, and they have been using this for extended period of time without even consulting any ophthalmologist, without seeking any review for any IOP measurement. None of the patient is knowing the potential side effect of these drugs. Absence of medical supervision, most of these patients rely on the local pharmacist or a general practitioner available over the sub-center or the primary health center over there. And these people who are available there, they are not well expertise in managing ocular allergies. They just dispense the steroids over the counter and unjudiciously, and also these patients are using these steroid eye drops unjudiciously for the extended period of time, and here we are. This is an avoidable cause of blindness, and the first patient that I've shown you, his vision in the right eye right now is finger counting at 1 meter. Now, who is responsible for this? Regulatory bodies, general practitioner, pharmacist, ophthalmology, and eye care professional, patient, and the public. Regulatory bodies, I would request for the stringent regulation to be made for the dispensing of these drugs, although these falls under the category of Schedule S drugs, but still they are dispensed over the counter. General practitioner, pharmacist, there must be educational programs for enhancing the knowledge of the general practitioner while dispensing corticosteroids. And we have initiated this in our center, and we are organizing a 15 days posting in every department so that basic medication they can dispense, and they must be knowing the side effect of these. patient and the public, as an ophthalmologist, we must advocate for the judicious dispensing of these drugs. Thank you. This is all from my side.
So, very important point highlighted. We're all been banging our heads against it. So, I just before commenting, I'll just take a quick head check. Rishu Kumari is there. Just be on the dais. Prasanna is there. Nimrita is there. Okay, Nimrita has come. Preeti Tripathi is not there. Tiruvedi Sai Tiruvedi Sai Yashwant, not there. Not there till now. Poonam, not there. Asmita Gope, okay. Rajiv, Virgis is there. Okay, great. Come in the front, Richard. Anuja Patil, not there. Pankuri, okay. All the speakers, please come on the first two rows. Durga, okay, wonderful. And Kirti, no. So then we can, accordingly, we know how much time to give because we must finish by 11 o'clock. So my take on this, whether each of us can give one comment each. So a very important topic you've highlighted. Sir, there is a regulatory body which prescribes, it says, but it is not being implemented. And there was a very interesting study from Chitrakoot, a very large study on BKC children being given the steroids. And mind you, they were prescribed 80% by doctors, by qualified doctors, not the quacks or the chemists. So we need to regulate ourselves whenever we prescribe steroids or whenever we see this. We educate the families and we tell the patients, especially BKC, that this medicine can cause problems. Do not use it over the time. Use it only for 2 weeks or 2 months and write it on. What I do is write the mother's or the father's name on the OPD card. Let's say you, Abhishek, your son has this. आप ये दवाई 2 हफ्ते के बाद नहीं डालेंगे. You will come and check. Otherwise, it can, and you make them sign. It's a very small thing I'm telling you. You make the parents accountable. That's for children. For adults, you just have to tell them that's for the blindness, but it's already too late. So to prevent it, we have to be accountable, and that's exactly what I was saying, antibiotic steroids we are giving as a drop of a hat. Last epidemic in 2023, I don't know how many of you saw Moxie-Dexa combinations being used, right? What was the rationale for a viral epidemic in antibiotics? So we need to relook at ourselves. Last was VKC. Does this child have VKC?
Yes, ma'am.
You gave brimonidine to the child and prostaglandin. For a steroid responsive glaucoma, that would not be my first line. Over to you.
Absolutely agree. We all have to take initiative on stopping this steroid use. Every prescription that you write steroids, even for post-op, you have to give the instruction when to stop in writing. Okay, otherwise we are liable. There's no less this thing. Having said that, I really want to re-emphasize what Dr. Kirti said, that the antibiotic use. Actually, in Karnataka government now there is a policy that you cannot give even oral antibiotics unless you have proved that there is it is a bacterial fever. So first 4 days of 1 week, the physicians also do not give antibiotics to prevent antibiotic abuse. So we are also liable if we are giving antibiotics just like that.
Well presented. So we published way back in 2013 that I come from a tertiary care center from North India. So what we see is we see 4 VKC children with steroid-induced glaucoma who undergo surgery every month in our center. And we had published that 1/3 of them are unilaterally blind when they come to us. And we all would be surprised that maximum people who are actually, prescribing these medications are not physicians or general practitioners, they're ophthalmologists who are not checking fundus, who are not checking the IOPs. So it is us who are to blame for this menace, and it is never ending. It is not ending. We also tried to, to bring about some change. We published in the newspapers to create awareness, but this still needs to be tackled with, at the
You are a GSI member. Let's have the next slogan: Stop Steroids. SS. Next GSI campaign of the glaucoma week should be Stop Steroids. Stop Steroids. We can have some catching things.
I know.
Let's join hands.
Something needs to be done. So I also take this opportunity to thank you, Dr. Abhishek. It was wonderfully presented, and we have a similar case by Dr. Rishu now. You can come onto the dais. And she'll be presenting on unmasking the menace, steroid abuse in VKC.
Prasanna and Nimrita to be ready.
morning, respected judges, seniors, and one and all present here. The topic of my today's presentation is Unmasking the Menace, Steroid Abuse in VKC. Before beginning with the case, I would like to give a brief introduction. VKC is a recurrent bilateral seasonal allergic inflammation of conjunctiva. It primarily affects boys, generally 5 years onwards. Steroids used for severe exacerbations. Steroids reduces conjunctival activity, leads to corneal improvement. Use of topical steroids without prescription is very common in India. A 10-year-old male complained of itching, watering, redness in both eyes since 3 years, presented to our OPD 1.5 years back, and he had similar complaints and treated elsewhere with steroids for more than 2 years. He is now addicted to moxi, fluoxetine and dexamethasone combination, also on tacrolimus, timolol, maleate since April 22, and he doesn't have any systemic illness and non-significant family history. On examination, the best corrected visual acuity of right eye is 6/24 and IOP is 50. Rest everything is within normal limit. And left eye best corrected vision is 6/12 and IOP is 21 mm of Hg. On fundus examination, the cup-disc ratio of right eye is 0.9 and left eye is 0.7. So based on history and examination, our provisional diagnosis is VKC in both eyes and steroid-induced glaucoma, right eye more than left eye. We prescribed him oral anti-glaucoma medication and topical, and still the right eye IOP was not controlled, so we modified the treatment and added torcelamide and timolol along with bimetoprost in right eye. On investigations, this is the OCT RNFL report of the patient with signal strength 3/10 in right eye and 2/10 in left eye. Here the average RNFL thickness is less with 68 micrometer in right eye and 48 micrometer in left eye. Vertical CD ratio of patient is 0.86 in right eye and 0.76 in left eye respectively. And now the pachymetry shows the central corneal thickness is within normal limits, which indicate that the IOP is not falsely elevated. This is the central 24-2 threshold perimetry report of the patient using stimulus 3 CETA standard. This is an unreliable field with fixation loss of 14 out of 18 and false positive report as patient is a trigger happy patient. On further follow-ups, the IOP of the right eye is uncontrolled even with maximal anti-glaucoma medication. So we had to do right eye trabeculectomy plus mitomycin C, and on post-op day 1, right eye bleb is shallow, so digital massage given, and after 3 weeks follow-up, the right eye bleb is now well formed and IOP is still high. So anti-glaucoma medication started, and on further follow-up, the right eye IOP is still uncontrolled. So we had to do needling of right eye bleb and subconjunctival mitomycin C. And we found that the right eye bleb is non-functional and the IOP is elevated. And the left eye IOP also show a rising trend. This is a slit lamp photo post-operatively of the right eye. And on further follow-ups, the left eye IOP, as mentioned there, it is also rising on anti-glaucoma medication. So we had to do left eye trabeculectomy plus mitomycin C in left eye as well. And now on post-op day 1, left eye bleb is well formed and IOP is low, and so bandage applied. And on further follow-ups, right eye IOP is constantly elevated, and left eye IOP is somewhat controlled. On in the latest follow-up, the right eye bleb is diffuse and the flat, and left eye bleb is well diffuse and left AC is well formed. This is the post-operative slit lamp picture of the left eye. So on follow-up, patient is under brinzolamide and brimonidine eye drop combination in the right eye as IOP is uncontrolled. IOP of the left eye is well controlled post-trab. So the patient is on cyclosporine both eye and the lubricating eye drop. So literature in steroid-induced glaucoma develops due to topical system periocular inhaled steroid results from reduction facility to aqueous outflow in a study by Saint et al. Of 1,422 three children with VKC 24 were using topical steroid without prescription 47 tablets steroid. So take home message is steroid-induced glaucoma is iatrogenic and preventable. Injudicious use of steroid should be avoided. Practical and safe guidelines for steroid use should be followed, only to be prescribed if the benefit outweighs the risk. Alternative selective immunosuppression should be considered. Thank you for your kind attention.
Smriti would like to say something, sitting there very quietly. Why can't we start from that side, ma'am?
So actually, I just want to restart Dr. Preeti's question that why brimonidine and
PG,
prostaglandins.
here also
Yeah.
PG and alpha agonist both were given.
So the first choice of drugs in my hands would be beta blocker and CAI inhibitors in a steroid-induced
How
glaucoma.
about you, Shikha?
So as it is, these are children, so we don't, we avoid. Plus they are already inflamed eyes.
Yes,
We don't want to start
How
with.
about you, Geeta?
Beta blockers and non-blockers.
So I think one message, because the three cases together we can see that these are sick conjunctiva and these are inflamed eyes. Uveitic glaucoma, steroid-induced glaucoma, sick conjunctiva is unhealthy or it's an inflamed. So PG analogs should not be the first line. Alpha agonist should not be the first line. Beta blockers can, and the other one is carbonic anhydrase, and of course you have astaxanthin. The other thing I would like to point out here in the medical management, cyclosporin you used was 0.02%. That is no good for VKC. You have to have 2%. 0.02% is anti-inflammatory for the tear film. For that, it's a mild, very mild T-cell inhibitor. So it has to be 2% for it to be effective. And the other thing I would like my house to opinion. So one is that medical management, at least we are clear on that. And second thing is, moment you have a VKC trap, like both the cases did a VKC trap, try to control the conjunctiva. It's a steroid responder. You can't do anything about that. So again, start cyclosporin or tacrolimus for 2 weeks. Make the conjunctiva healthy, because what you showed, the needling and everything, because the pleb does fail. The young children, anyway, the failure rate is high. Plus, this is a conjunctiva which is inflamed because of VKC. So control the VKC first by the non-steroidal, which should be cyclosporin or tacrolimus. And if you have to give steroids for control of the VKC, then add astaxanthin. If you operate in an angry conjunctiva, you're going to bound to have these failures. Your take.
Yeah, no traps in hot eyes, basically, as we say, whether uveitis or VKC. So you have to prep the conjunctiva. If steroids are not possible, cyclosporin, even Trehalute seems to have some anti-inflammatory action on the conjunctiva, along with copious lubricants, is something that you should prepare so that you can improve the outcomes of your traps or any flare-based surgeries.
So sometimes, ma'am, actually raise a very valid point. So sometimes these patients need to be admitted because we need to control the conjunctival inflammation, the papillae are huge, and we have to give them mannitol. So, but it's important to medically control than intervene in a hot eye. So that is the key hope.
So that's my key message coming. Don't do a trap in a hot eye. You're going to lead up into problems. Anything added to that? So I think wonderful discussion, well presented. Next case you can introduce.
Yeah, so now I think we have Prasanna Reddy presenting an atypical case of ripostidil-induced late onset choroidal detachment and idiosyncratic RNA. Go ahead.
Thank you, ma'am. Thank you, AIOCMT3 for this opportunity. So I'm going to talk on an atypical case of ripostidil-induced late CD. Early choroidal detachments are well documented after trabeculectomy and glaucoma drainage surgeries, especially due to overfiltration, and they are having an occurrence rate of 11 to 19% post-trab and 16% post-DDD. Late onset CDs are a very rare complication in our clinical setting, and previously there have been few other anti-glaucoma medications which were reported with late onset CD, whereas there has been no mention of ripostidil as yet, and especially a spontaneous CD, and this was one of the cases of mine which I wanted to share today. A 60-year-old male came for glaucoma review. No history of any comorbidities. He's using bimetoprost for 12 years, and the visual acuity best category was 612 and 69 in both eyes with a near GOA, as well as he had a grade 2 cataract. So IOP was not necessarily in the low teens, which I would really wanted it to be. along with a mean deviation of severe damage in the functional aspect. So he was diagnosed as advanced primary open-angle glaucoma with glaucomatous optic atrophy with right eye greater than left eye, and I wanted to go ahead and operate the right eye first with the trabeculectomy and PCOL implantation, along with an anti-glaucoma medication to bring the IOP in the left eye to low teens. So this was the post-operative 1 week picture. Blood was good, anterior chamber deep, surgical PI present, pseudophakic, BCVA was 6.6 and IOP was 13, and everything looked well as was anticipated in the first week of follow-up that we see this patient. And then come 2 months follow-up, as subjectively we are following up the patient. So the IOP, which was previously 13, has gone to 18, and in this patient the target IOP definitely would want to be in the low teens and not 18. So 13 to 18 was a concern, and riposodil was started 2 times a day for the right eye. And then for 2 months he was fine. You can see from post-op 2 months to 4 months. So he's been using riposodil for 2 months, and then when he comes here, complaints of blurred vision for since 2 weeks, and the AC is shallow, the blood is fat, IOP is 5, and this is the B scan picture. So after that picture, riposodil was advised to stop, and topical steroids and systemic steroids was begun, and then you can see the vision slowly improving from 6, which was actually very less. You can see it has now come to 6.9, and the IOP has recovered to 10. And this is a B scan picture which recovered within 1 week. So furthermore, the patient did not experience any recurrence of CD as the medication was stopped. So this was the complete 360-degree mosaic as well as the B scan in before treatment, and this is after treatment. And now the patient is having a follow-up of 14 months. You can see how it settled within a week. There is a causal relationship. To prove causality is to re-challenge, but re-challenging may not be ethical because sometimes it may fail to reproduce the event. And this patient, after 6 months of that particular late CD, the IOP was still not able to be under target, so we did put the patient on the prostaglandin analog, and that is not showing any adverse effect, and things are looking good. The discussion per se, there are 2 mechanisms in which you can have this. One is the suppression of factors where these 3 medications are prone to it. One is the increased uveoscleral outflow, where the ciliary body is first damaged or sensitized, and then you have the sensitized ciliary body reacting with a dramatic response. On the other hand, if it's a uveoscleral pathway, then the reduction in the level of collagen 1, 3 and 4 will be the culprit for the uveoscleral outflow overflow. In this, the idiosyncrasies could be the possible mechanism here is post-trap status, IOP was not in the low teens, and when riposodil was added, you had this kind of a domino effect where it really went into a low setting of IOP which caused the low onset CD post-trabeculectomy surgery. So the direct action of riposodil, it's an outflow drug directly acting on the trabecular meshwork, and the ROC is actually an important downstream effector, whereas this one is a completely a reversal of it, which is an inhibitor causing a paradoxical response. And why riposodil was given in the post-op for the target IOP, it is very bleb friendly, suppresses the subconjunctival fibrosis, and the application of it really helps us after a trabeculectomy in maintaining the IOP, and it doesn't really harm the blood. So to conclude, we report a case of a late onset CD, especially after topical riposodil, where it took the IOP into a low IOP hypotony with CD, especially in those settings, and it resolved on the withdrawal of this drop after conservative management. So these are my references. Thank you.
Thank you, Dr. Prasanna, for an interesting case. So it does happen not only with riposodil but with many other anti-glaucoma medications, that is idiosyncratic. Did you happen to check the CDLs in this case, because the bleb was avascular when you showed the picture?
Yes, ma'am. CDLs also was checked, but there was no history of any CDLs positive, as well as the bleb was also not overfiltering, because
so there was no sweating of the bleb, because that could also lead to late onset hypotony sometimes.
Yeah, that was also part of the differentials, ma'am. In the first week the bleb looked fine, but actually after that the bleb really went totally flat. So
yeah. So in case you feel that there is something, so you can always do some compression sutures or maybe conjunctive advancement. Another thing is, these patients tend to show this idiosyncratic reactions for their lives. So not only with riposodil, you have to be careful whenever pymatocross, the patient is doing fine, but whenever you add another, just tend to monitor the patients, and these patients are refractory. You stop the medication, they'll be fine, they will come back with high pressures, you institute the drug again. So these are recurrent choroidal effusion cycle patients. So I have had a very bad experience, 5-6 cases, not with ripasudil but other patients. They tend to come in cycles.
Though the patient is in 14-month follow-up, I was very skeptical to restart even prostaglandins because I wanted the IOP to be slightly lesser, because after 10 now slowly it's starting to come up. So I hope I'll
So
not
don't
have...
bring the pressure too low also.
Yeah.
And don't ever give Dimox.
Yes.
So sometimes
Comment from Dr. Smriti has just joined us.
So, ripasudil, long term, what do you feel? Have you ever seen any honeycombing of the cornea?
No, with the netarsudil I have seen, ma'am. With ripasudil I have seen more of pinpoint subconjunctival hemorrhages. I have
So, you
not...
can continue it for a longer time? You feel?
Netarsudil, whenever I see the honeycomb, I discontinue it because I don't want it to really, harm the cornea in that angle. So I have seen 2-3 cases with the netarsudil, not with
ripasudil. Because this is my question, like if we put them on long-term ripasudil, then what are we headed for? So at some point again we'll have to change the drug or do something.
For me, in my armamentarium, I'm using it as a third or a fourth line medication. Especially in this scenario, why I brought it here was more blood friendly. That was the angle that I went with ripasudil in the post-op for this scenario.
So, in answer to that question, in bad corneas, honeycombing you see even with ripasudil, and that can start early also. Yes, it can start early and it stops also. It stops once. Yes,
Decompensated.
Yeah, we had seen, like we had done a study which was published in primary congenital glaucoma. We had given netarsudil and it led to almost 100% honeycombing. So the cases which are surgical cases where the IOP is not getting controlled, there is no filtration, so it tends to accumulate in the epithelium. Right. So in those cases where the pressure is very high and it's not responding, in those cases which are responding, they will not show honeycombing. Honeycombing will be seen in the eyes which are not responding to your drugs with high pressures.
So one angle I would like to say, everybody may or may not agree, but in a situation like that, ripasudil may be blamed for the idiosyncratic effect. As many drugs, we have a list of drugs. But also we need to understand there are certain eyes who do not tolerate low pressures, just like that after trap. So it may not be ripasudil, it may be any drug that you would have started. Pressures go below 10 and you present like that. So if we tell a drug being responsible, we usually check the second time we give the threat. So that means if you restart the ripasudil and the patient goes into this kind of a thing, then we say that blame the drug. But I would still be thinking in terms of it may be just the low pressure rather than the drug.
The ripasudil may just be the scapegoat.
Yeah, I thought about that, ma'am. It was so tempting to restart actually.
Yeah.
That was why I put that point.
But the patient has to be explained.
The ethical
So
point of view
interesting
was
case
holding
about
back.
this thing. I have just one question on this.
Yes, ma'am.
That which you said was ripasudil, which you explained very beautifully. That's more of a bleb-friendly drug. Having said that, with the 18 pressure, even a bleb-friendly drug, the only pressure reduction maximum it does is 3 to 4 max. So again, I would have personally favored beta blocker or something which causes an aqueous suppression vis-a-vis something which causes a more of an aqueous outflow or increase. But very beautifully presented. And one take on it, supposing this recurrent CD happens, would we give a long-term cycloplegics for these patients? Message to take home? Because how to ensure that the next time, like this is a cycle, they'll go on high pressure, then again you'll need something, then again they'll go into that.
Yeah, at least an intermediate term cycloplegic is what I would prefer in these patients, at least for a month or two, if not long. If it is really
I
a
would
bad...
say once a week or something, every Sunday you give some cycloplegic and just manage it like that. If there's a repeated thing, not once, not for the one time. If it becomes okay, and I would, again, this is again a personal anecdotal experience not published, go for a needling, plain needling, just not with mitomycin. If it's an early bleb failure, just try a plain needling with saline and just break the nascent fibrotic bands rather than going for a drug. Because all drugs do have issues. So beautiful.
Thank you.
And very good discussion. It's good that you're having these discussions. It's a good learning exercise. Maybe who's the next person?
So we next introduce Dr. Nimrita. She will be talking about choroidal detachment following gap surgery in PACGI.
Has Preeti come to
Good morning everyone. My topic for case presentation.
Please start.
My topic for
Slides. Slides.
my
Start.
topic. Good morning, everyone. My topic for case presentation is a rare case of choroidal detachment following GAT and primary annular closure glaucoma. A 54-year-old male patient came with a gradual progressive decrease in vision in both eyes, right eye greater than left eye, since 4 months with status post peripheral patent PI, and was on 2 anti-glaucoma medications, alpha-gain and timolol. On anterior segment examination, IOP by GAT in right eye was 22 mm Hg and left eye 18 mm Hg. Visual acuity in right eye was 660 improving to 636 and in left eye 618 improving to 69 with patent LPI in both the eyes, and right eye had nucleus sclerosis grade 2 with posterior subcapsular cataract and left eye nucleus sclerosis grade 1 to 2. On undilated gonioscopy, both eyes showed grade 0 and which open on indentation to PTM 2B except in right eye which had passed nasally. On dilated fundus examination, right eye showed 0.9 inferior rim notch with superior rim thinning and left eye pointed superior rim thinning. On visual field examination, 24-2 and 10-2 for right eye showed advanced visual field defect. After 1 month, the patient presented with high intraocular pressure in both the eyes, so PG analog was started for both the eyes. So after 2-week follow-up, IOP was still refractory. Right eye had more IOP than left eye, so surgical management in the form of combined GAT with phacoemulsification was planned. These are the steps. After phacoemulsification, the phytoprolene suture was blunted, and then GSL was performed with cyclodialysis spatula. Nasal goniotomy incision was done. Then the blunted tip was passed to the Schlemm's canal and retrieved from the other side after completing 360 degree. Post-operatively, a tapering dose of Dexorin S was started. Pilo was given BD for 2 months and Nepalac OD for 2 months. On 2-week follow-up, the visual acuity was 636 improving to 624 with a low IOP of 5 mmHg, and on dilated fundus examination it showed peripheral 360 CD which was confirmed by B-scan. AIOCMT was done to rule out any cyclodialysis left which was not there. So, conservative management was started, tapering dose of steroids was continued, Pilo was stopped, and cyclophagic in the form of atropine BD was started for 2 weeks with systemic oral steroids. On a 3-week follow-up, visual acuity improved from 612 to 69 and IOP also increased up to 14 mmHg, and dilated fundus examination showed complete resolution of 360 degree CD which was confirmed by B-scan. Coming to discussion, CD has been is seen as an early complication post-trabeculectomy in 7.9 to 18.8% of the cases. Risk factors include old age, a large difference between pre and post-trabeculectomy IOPs, thicker corneas and hypotony. Mix is now being explored in primary angle closure glaucoma and also in advanced angle closure advanced glaucoma, and has comparatively non-vision threatening post-operative complication. So the potential causes can be due to surgical trauma, acute hypotony or low IOP, and vitreous disturbance. So this was a study reported by Agachi et al. In which GAT was done in 33 eyes of open angle glaucoma, and ciliochoroidal detachment was seen in 14 eyes, which was seen by the AIOCMT. Another study by Sharkawi et al. In which GAT was done in primary angle closure glaucoma of 103 eyes and only 1 patient showed low IOP. Another study by Yan et al. In which GAT was performed in open angle glaucomas and only 3 cases showed supraciliary effusion and ciliochoroidal detachment which was resolved after 1 month after surgery. So why this case? Till now, very few literature has reported choroidal detachment after combined phaco-GAT in primary angle closure glaucoma. And to conclude, choroidal detachment following GAT in PACG is a rare complication that can be managed conservatively, and it does not affect the long-term outcome of surgery. These are my references. Thank you.
Thank you. Can we take the
Yeah. Hi, Dr. Nimrita. So I have a question for you. So you said that there was no cyclodialysis.
Yeah.
But how do you test for cyclodialysis? What is an instrument that you use to see for cyclodialysis clefts?
No, we did the AIOCMT and
So AIOCMT does not tell us about cyclodialysis at all. swept so air-associated that the case here it may or may not show you, but the air-associated that you showed, it did not show ciliary bodies at all. So we don't see you're not ever sure. So did you do gonioscopy in your case?
Yes, we did gonioscopy. On gonioscopy, it was not seen the clefts, ma'am.
So why is it you showed that it is very rare to have hypotony after GAT? There are 1 or 2 cases and those 2 had cyclodialysis clefts. So why do you think it is rare to see hypotony following MIGS?
Ma'am, because there can be surgical trauma.
No, why is it rare? Why it doesn't happen? Like in trabeculectomy you showed it's very common. But why after MIGS it is so uncommon that you have to have an etiology for it? Why is it uncommon?
When are you targeting? What are you targeting with MIGS? Any MIGS? GAT?
The French canal, the trabecular.
So ROP cannot be lower than your episcleral venous pressure ever. So you have to have an etiology. So you have to have a cyclodialysis cleft. That's my take on it. Without it, you can't have choroidal, and it healed on its own. You gave steroids, it healed on its own. So, but you missed it. So that's okay. So very few cases require surgical treatment if you have cyclodialysis cleft. But what is the etiology of cyclodialysis cleft after GAT?
But ma'am, the pre-op IOP was high only.
Yeah.
The mixed surgery is not done if the IOP is lower than episcleral venous pressure. But in our case, the IOP was very high only. So that cannot be considered as an risk factor to cause cyclodialysis cleft.
No. What madam is saying is the whole pathophysiology of how the mix works is through you will break the Schrem's canal and you're using the trabecular meshwork the outflow pathways.
Yes.
So outflow pathways are not impacted. So it cannot go beyond the uvular pressure. Whereas in trab, you are making a bypass. You are touching the ciliary body and therefore you have a high chance of cyclodialysis or ciliary body shock. So the reason that after GAT or any other mix, the hypotony is so low is because it cannot go below the uvular pressure. That's what ma'am is trying to tell you. And that's what she's saying, that probably you've missed the cyclodialysis cleft and ASOCT is not the correct tool. Gonioscopy or if possible UVM would have taken it out. Any take on that?
I have another small question for you. Actually. Yeah. So, what was the intraocular pressure immediate post-op? The next day, first day post-op?
Ma'am, the first day IOP was 10 only, but on 2-week follow-up it went to 5 mmHg. So
It went down.
yes, ma'am. Yes, ma'am.
Yeah, I think definitely to look for a cause whenever you have a hypotony after mix, and UBM would be the best tool if you are not able to see it through gonioscopy. I understand doing UBM is also a challenge when the pressure is low, but we definitely have to look for a cause unlike trap.
And do we need to do a UVM if the pressure is low and it's resolving on its own? Because it is a challenge and you just kind of wait, you give time to try, let me say. So good discussion and well presented. Can we have the next person and the other 2 people ready, because we only have 25 minutes left. So we have 3 people we have now. Virgis, then we have Pankuri and Durga. So Pankuri and Durga, please be on the front. Yeah, please carry on.
Good morning everyone. I am Barji Sakak and I will be presenting a case which I titled LASIK Lift, Pigment Drift, IOP Shift. While I unleash the post-LASIK eye pressure mystery, you will come to know why it has been named so. So our patient is a 29-year-old male who presented, who was an engineer by occupation and an RI, who came to India with the hope of becoming spectacle-free, and he underwent both eye uneventful LASIK elsewhere, and he was referred to us with uncontrolled IOP on maximal medical therapy with right eye blurring of vision and pain post-surgery. He was diagnosed as steroid responder, and before sending to us, all forms of steroids were stopped. On examination, his right eye visual acuity was 4/60 and in the left eye it was 6/6. There was conjunctival hyperemia, there was corneal edema, there were cells in AC with flare. Few iris pattern changes were noted, however they were not very clear because of edema. And there was IOP 45 on presentation and fundus was okay. Left eye examination was normal. Since there was congestion, there were cells, there were pigmentation, and IOP did not come down over a period of 1 week. So a likely diagnosis of herpetic uveitis was made, since it is precipitated by stress, and in our case it was LASIK. So we started the patient on oral cyclovir, prostaglandin analogs were stopped, and topical steroids were started. So over a period of about 5 to 6 days, the IOP did decrease on maximal medical topical therapy except prostaglandin analogs, however only to late 20s. The AC cells did decrease and the cornea became clearer. As the cornea became clearer, we were able to appreciate the iris details more clearly. There were circulating pigment cells noted in the AC and the pigment clumps on the peripheral iris. This is the gonioscopy of the affected eye, and we can see fine pigment dispersion obscuring all the angle structures. This is the picture of the other eye just for the comparison. So since the IOP did not come down, and with the fear of optic nerve disc changes, we decided to start the patient on prostaglandin analogs, and bimatopros was started. At this point, we were even considering surgical intervention. So miraculously, in about 2 to 3 days only, the IOP, which was not coming down by any means, did come down. The cornea became clearer, the AC was quiet, and there was a decrease in the pigment clumps noted. As we can see, there's a decrease in the pigment clumps over a period of 2 to 3 days also. This is the picture of the other eye, just for the comparison, that how the other eye looked normal. On his last follow-up with us, his visual acuity improved to 6/9. The IOP was within the normal range. However, we decided to continue the patient on one anti-glaucoma medication. He was spectacle-free and he flew back happily to his country from wherever he had come. So, actually, post-LASIK pigment release is notable, however, a very rare entity. The pigments released, they obstruct the and hence they decrease the outflow and result in the increased IOP. This can be due to the mechanical trauma or stress to the iris while LASIK, or due to rapid changes in IOP during LASIK, and also can be due to inflammation. Some patients are more predisposed to mechanical stress and pigment release, and the predisposing factors can be genetic or even anatomical. So it's very important for the early identification and management, and also proper mandatory history and examination is very important. So in our case, the patient experienced a violent release of pigment post-LASIK, causing high IOP with pigment deposition over the angle structures and spill over into the peripheral iris. Some degree of cells and flare was probably due to high IOP and the breakdown of blood-aqueous barrier. Administering bimatopros helped by opening up the alternate uvous scleral pathway. So my take-home message would be that it's very important. A proper history taking, glaucoma workup and fundus examination is definitely very important before all refractive surgeries. Need for gonioscopy before refractive surgery is debatable because since some patients are more predisposed to mechanical stress and pigment release, so gonioscopy might be helpful in identifying individuals and mitigating potential complications. And not to forget, the importance of frequent follow-up even in such patients of refractive surgery is important. Thank you.
So, thank you. Very interesting case. Can it be, again it's not reported after LASIK as to the best of my knowledge, can it be a body? Can it be a bilateral acute depigmentation of the iris, because you're showing the other eye was comparatively normal, although both eyes had LASIK.
Both eyes are LASIK.
But can it be a modified body which is known after antibiotics but not known after LASIK?
Yeah, so that begs the question, what was used post-LASIK and how many days post-LASIK did the patient present? So this part in your history?
It was like just within 10 days he presented to
So
us.
he was given oxychloroquine?
He was given antibiotic drugs. Yeah, not the combination, but he was given separately antibiotics for a week.
Which antibiotic?
I think oxychloroquine.
Chloroquine. Because that could be an etiology, although I don't think LASIK beyond its reporting I have not come across it.
I thought that it's the oral fluoroquinolones which causes.
No, topical also. There was a recent case where LASIK they used a bandage contact lens which soaked in moxicloxacin and they had a huge pigment release. So you can think of that as the etiology. And of course you thought of herpetic, but I don't know why you thought of herpetic.
This was just one of the differentials also, because really the IP was not coming down. Nothing worked actually.
So maybe steroids, did you continue to add steroids? That was
after
maybe you could have added steroids for a longer time, looking at the viral,
After we ruled out everything, then we started steroids.
Yes,
steroids were started, they were stopped elsewhere.
So these
and how was the iris configuration?
It seems to be normal. The
Yeah, it
vision
seems to
was
be
a
normal.
regular
However, the only
pigmentation.
finding was that the deposition of
Excessive
pigmented
pigmentation.
clumps.
360 degrees.
So what kind of LASIK was it? Was it blade LASIK or femto
So
LASIK?
it was the standard LASIK, not the femto LASIK. It was the standard blade LASIK and not the
Blade
femto
LASIK,
LASIK.
yeah. So in that
Yeah.
IOP can go really high and that can lead to
But pigment
underpigment
dispersal was short
release.
also.
Yes, there can be because of that. And there was one more comment. Steroids were used for how long post LASIK? As madam said,
They were started
steroids would have
immediately
been-
as a normal norm. They were started and they were stopped for within 1 week. They thought that it might be steroid responder.
Yes.
So they stopped it. When the patient, when we received the patient, he was off steroids. So we just
Yeah.
kept him off steroids only just to consider other causes. But then we started steroids.
Yeah.
Still after that, giving a period, like about 2 weeks, the IOP did not come down.
Yeah.
So we started PG analogs
Yes, so
because
the-
we had no other option before intervention. We were
Yes.
even considering taking the patient for trial.
Yes, so in LASIK cases, an alternative is to use cyclosporin instead of steroids if you want to control the
And
inflammation.
2% cyclosporin or 0.05?
0.05 is enough. You can just give it, three or you can give it in a higher dose also. We do give it for TPR case for corneal haze. It reduces that.
Okay,
And post
from the-
therapeutic PKs also we give.
From the line, if I'm not mistaken, there was a series of cases where intracameral moxifloxacin also has caused body.
Yeah, intracameral moxifloxacin has
So
caused
we
bad.
need, so we need to rethink of our, it's just reiterating excessive use of steroids, excessive use of antibiotics are not really giving us any benefits other than filling up the coffers of some pharmaceutical companies, which they are our friends, pharmaceutics. Without pharmaceutics, we can't survive. But please understand, we are answerable to our patients. We just cannot keep giving antibiotics, and not for this case. This was obviously you have to give something post-op, but we need to rethink our steroid and antibiotic policy. Really put a thinking cap on and introspect. So
Just one thing I want to add, another angle is that the fact that the prostaglandin helped in this situation is suggestive of more of a pigment dispersion due to microkeratome induced high pressure. So that is another indicator that's why I'm wanting to ask what type of LASIK was done. Good.
Thank you.
We'll just call Pankhuri Verma, presenter case, an unusual occurrence of angle closure glaucoma with retinitis pigmentosa.
Good morning everyone. I am going to present a case on unusual occurrence of angle closure glaucoma with retinitis pigmentosa. There is no conflict of financial interest. Prevalence of primary open angle glaucoma with RP ranges from 2 to 12%. Prevalence of PACG in RP patient over 40 years of age is found to be 1.03%. IOP elevation due to acute angle closure may aggravate the visual impairment in RP patients with pre-existing optic nerve dysfunction. Hence, angle closure related IOP elevation can be prevented by timely intervention in those susceptible eyes. So the case is a 34-year-old female presented with complaint of diminution of vision in both eyes, which was more in right than compared to left, which was insidious in onset, gradually progressive, with symptoms aggravating in dim light or at night. It was associated with headache from last 2 days, severe in nature, not decreasing even after taking oral medication, and not associated with any diurnal variation. The visual acuity in right eye was 1/60 and in left eye it was 6/9. In right eye it was improving to 3/60 and the pressure in right eye was 38 mm of mercury on gap and in left eye it was 36 mm of mercury. Cornea was clear in both eye, anterior chamber was shallow with VH1 and no AC pigmentosa cells were seen. On gonioscopy, in 2-quadrant ATM was seen along with Shalby's line in 2-quadrant with blotchy pigmentation. The pupil were mid-dilated and sluggishly reactive. Posterior subcapsular cataract was present in both eyes. On fundus examination, we could see waxy pale disc which was vertically dysmorphic and temporal crescent was present. FR was dull and severe arterial attenuation along with bony specules was present all around in the periphery. This is the gonioscopy picture showing the ATM in 2-quadrant and Shalby's line with blotchy pigmentation. OCT RNFL picture in right eye showing RNFL thickness is outside normal limit except in the superinasal quadrant in right eye. In left eye, in nasal and temporal sector, it is outside normal limit. This is the single field analysis of the left eye. As in right eye, the vision was very less, we couldn't perform HFA. In left eye, it was severely depressed and glaucoma hemifield test was within outside normal limit. On ASOCT, we could see that the anterior chamber angle is shallow in both the eyes. It is 16 and 12 in right and in left eye it was 2019. So the case was managed by left eye YAG PI was done and the pressure decreased to 11 mm of mercury. In right eye the PI was done under mannitol cover as the pressure was not decreasing. In post PI also the pressure remained to be on the higher side. So then right eye phacoemulsification with PCI with trap plus MMC was planned and the pressure came to 13 mm of mercury in right eye and in left eye it was 11 mm of mercury. The vision improved to 3/60. This is a post-op picture showing the bleb is formed, a PCL is in situ and AC is formed and surgical PI is patent. The vision I have already mentioned 3/60 and 6/9 and the pressure was again controlled. So coming to the discussion part, previous theories regarding glaucoma in RP suggested that the migration of pigment is a characteristic feature of retinitis pigmentosa and these pigments in the angle of the anterior chamber has been stressed as a possible etiological factor in glaucoma. The ultrastructure of the lens in RP is altered, causing lens fiber disorganization, which may contribute to the instability of the lens with anterior displacement and narrowing of angle. Recently, zonular instability is speculated to be the cause behind angle closure in RP patient. Zong et al. Exploration using whole exome sequencing discovered that 5 genes CRB1, COL2A1, RHO, RP1L1 and PAP6 were responsible for the genetic association between early onset PACG and RP. And the predisposing factor for ECG in RP and nanophthalmos, cataract, lens subluxation, increased lens thickness, anterior segment dysgenesis, and short action length. Current therapeutic strategies for PACG comprise laser, medication, or surgery. So the take-home message is, tubular visual field might be observed in the patients of RP or PACG at the later stage. Therefore, atypical glaucomatous optic disc, similar visual field effect, and the incidence of rarity may lead to the higher risk diagnosis rate. Hence, comprehensive ophthalmic examination, including gonioscopy, full-field ERG, macular OCT, and genetic testing should be done in younger RP patients in clinical diagnosis. Early intervention and maintenance of the target pressure can lead to a maintenance of the vision. Thank you so much.
Thank you. We'll have the last presentation by a case report on malignant glaucoma by Dr. Durga, and we'll take Pankuri's and Durga's case discussion at one time. So just be around. Thank you. Anybody else who's come whose case was here? Okay.
A very good morning everyone. I am Dr. Kirti and I am here to present a case report on malignant glaucoma. A 53-year-old male patient presented to us with complaints of redness, pain in right eye since 1 week. He gets being operated for cataract in right eye elsewhere 15 days ago. Patient was on topical anti-glaucoma medications and cycloplegics and steroid eye drops by the time he presented to us. On examination, the visual acuity in right eye was perception of light present and IOP was 50 millimeters of mercury. There was diffuse conjunctival congestion, corneal edema, and flat anterior chamber and a mid-dilated fixed pupil with a posterior chamber intraocular lens and a hazy posterior segment. These are the clinical pictures of the patient showing a hazy cornea with a flat anterior chamber with total iridocorneal touch. We performed a B scan in this patient which ruled out any other posterior segment pathologies, and on anterior segment OCT, it showed iris plaster to cornea. Patient was given maximum topical medication along with atropine and also oral anti-glaucoma medications. Multiple YAG peripheral iridotomies were tried and also YAG hyalerotomy was done on this patient, despite which the anterior chamber remained flat and IOP was raised. This links us down to the diagnosis of malignant glaucoma. What could be the differential diagnosis in this patient? As it is an early postoperative complication with higher intraocular pressure, it could be a suprachoroidal hemorrhage which is excluded by the B scan, as well as a choroidal effusion which is a early postoperative complication with shallow anterior chamber, as well as it doesn't have a high IOP but a low IOP, which is also ruled out by the B scan. And it could also be a pupillary block glaucoma, which is ruled out by the presence of a patent PI. So we went ahead and performed right eye pars plana core vitrectomy with anterior chamber reformation and a surgical PI was performed. At POD1, the IOP came down to 38, corneal edema decreased, AC was well formed with 1+ cells and a patent PI was present. We asked the patient to continue topical anti-glaucoma medication along with cycloplegics for a long-term period and topical steroids. These are the post-operative pictures of the patient with a cleared cornea and a formed anterior chamber. But patient, when followed us up at 1 week post-op, he had stopped all the anti-glaucoma medications and just continued the steroids. The vision improved to 624, but the cornea was hazy due to microcystic edema. Anterior chamber was deep, and the IOP was 52, and the fundus examination showed a cup disc ratio of 0.55. We asked the patient and explained strict LGM compliance to continue steroids as well as cycloplegics and anti-glaucoma medications, both oral and topical. These were the post-operative second week pictures of the patient. The vision improved to 612. The IOP came down to 22 with maximum medication. AC was formed and it was 0.55 CDR, and patient was on topical AGM and cycloplegics. These are the anterior segment OCT pictures of the patient post-operatively, which showed a formed anterior chamber with a patent PL. So in this patient, the vision improved from PL positive to 612, IOP reduced from 53 to 22 millimeters, and also the AC deepened from total flat AC to a deep AC. So malignant glaucoma is a dreadful complication which is most commonly seen in 2 to 4% of angle closure glaucoma cases and in any other incisional or in a laser procedure. It was described initially by Von Raffet as uniform shallowing or flattening of anterior chamber, both central and peripheral, despite one or more patent peripheral iridotomies, and it could be with normal or when elevated intraocular pressure. It could be medically managed or even laser and surgical procedures are advised. Laser, we can do an ND-arc laser hyaloidotomy or slit lamp needle revision for disruption of the anterior hyaloid vitreous space. A pars plana fluid aspiration was advised by Chandler et al. An organ laser cyclophotocoagulation can be performed either transleral or endolaser. Surgical performances can be pars plana anterior vitrectomy with anterior chamber reformation. In phakic patients, a combined vitrectomy, phacoemulsification and a vitrectomy with zonulo-hyaloidectomy can be performed. Whereas in refractory cases, a complete pars plana vitrectomy is advised with an entire hyaloid face end face removal with a lens removal and creation of a vitrectomy tunnel. A long-term treatment outcome study was performed on malignant glaucoma, which showed female gender and PACG patients were more prone, and medical treatment alone was inadequate, and vast majority required surgical intervention for a better results. Conclusion: early intervention, including medical and surgical, is required to prevent from permanent visual loss. Prophylactic fellow eye peripheral iridotomies are preferred in high-risk cases. Thank you one and all for giving me this opportunity.
Thank you, Dr. Durga. What if it was an excellent presentation, but what if I, beg to differ that it was not a case of malignant glaucoma at all? So what is one diagnostic modality that you must have used to confirm your diagnosis?
An ultrasound biomicroscope could have been better done.
What if I say that the etiology was primarily a wound leak post-cataract surgery, which led to this presentation, and not malignant glaucoma per se? Was this in your differential diagnosis?
If it would be a wound leak, the patient would have presented, but though the AC was flat, the IOP was entirely raised. So
a wound leak would lead to that picture. Did you do a capsulotomy or a zonulectomy and hyalidectomy at the time of surgery? Because that was not mentioned in the slides.
Initially, the patient presented was post-operatively. The cataract surgery was performed elsewhere. So when
you surgically intervened, yes, was there a tunnel created between the anterior segment and the posterior segment? You mentioned that you did a vitrectomy and an hyalidectomy.
Yes, ma'am. We did not do a zonulectomy and a capsulotomy, but we tried a ND-arc laser disruption of hyaloid vitreous space through the capsulotomy that we have performed through the ND-arc laser, not the surgical one.
Other thing is when it recurred.
Did you give cycloplegics? Atrophy?
Yes,
I didn't see anywhere.
Yes, ma'am. It was given initially.
I missed that.
Okay. And when it recurred again, the AC was deep. So that also goes against the diagnosis of malignant glaucoma. When it recurs with high pressure, it should have again presented with shallow AC. So all these things, I feel that your primary diagnosis was wrong maybe.
Yeah.
So because a tunnel creation is a must if you're dealing with a malignant glaucoma, and UBM is also a must to look at the.
Yes.
Plus when you showed that AIOCMT picture, the lens was posteriorly placed. It should also have moved forward.
Yes.
Yeah. Just
pass. Right?
Yeah. What was the other eye status of this patient?
The other eye was a phakic eye, ma'am. He wasn't operated. It was 612.
And the biometry, the anterior, what you call the anterior chamber depth, lens thickness, axial length, anything?
The other eye, actually, as the presentation was shorter, I didn't mention the details of the other eye. The anterior chamber was deep, and the biometry, the lens thickness was within normal limits. It was not a thicker lens.
And Brinzolamide and dorzolamide should not be given simultaneously. I noticed pre-operatively patient was on.
Yes, ma'am. Before he presented to us, he was using a combination of drugs, and drug was given twice.
Yeah, so that is something that I wanted to mention, that
Yes.
same group you cannot be using two drugs. That is just to.
Absolutely. So for the previous, it's well presented. The previous one was about the angle closure glaucoma with retinitis pigmentosa. I have two questions on that. Was the lens ward studied? Because you have the ASOCD. What was the lens ward and what was the justification for doing a phaco trap?
Lens volt was from 4.36.
So why was a phaco trap done and not just a trap?
Because we came to because of zonular instability, lens could be subluxated.
No, would be, or did you prove it?
No, it was not there. Like intraoperatively, we didn't find any lens subluxation.
So why take out the poor lens when it's not doing it?
Ma'am, PSC was also present there.
Significant PSC?
Yes, ma'am. In right eye it was there, so we moved with phaco trap.
Any comments on how the
That's a surgeon's prerogative.
Yeah,
We usually don't prefer doing both the surgery, especially in a young patient.
especially young patient, RP patient, you would like to keep the, but if there was significant PSC, great, then you would take it out, but why do a combined surgery in that situation?
And another point that I would like to make that although the Caucasian books that we read, they all say that retinitis pigmentosa is associated with open angle glaucoma, steroid-induced glaucoma is associated with open angle glaucoma, Fuchs heterocyclic iridocyclitis is associated with open angle glaucoma, but in our population, we do see angle closure glaucomas with all these subsets.
Yes.
And in PSCGY patients, especially angle closure glaucoma of the young, they are associated with inherited retinal dystrophies to a greater extent. That paper also showed the Chinese paper with Song et al. And we do also see a lot of macular dystrophies in these patients. So vice versa, also if you're seeing a young angle closure glaucoma patients, we must do a dilated retinal examination. And so to conclude,
In fact, we also see in myopes, again the Caucasian studies say that myopes, we don't have angle closure glaucoma, we do see with myopes angle closure glaucoma because our population is different. So just concluding remarks because I think the other,
Just usually in these young patients it's related to zonular weakness as she pointed out.
So thank you very much to all the judges and to the speakers, and it was very wonderful learning.
it was a very wonderful learning experience. So good luck, good job, all of you. Thank you.
Thank you very much. Group picture for
Excuse me, there are please here. Wait. Just a moment.